Thanks so much for inviting me, and it's a pleasure to be here. We've heard the results of an 88 million euro investment, a grant that came in right at the beginning of the acute COVID pandemic, that this new virus with research in genetics, virology, immunology, gut, blood, and other clinical studies. And we've heard about those studies today, and we could go on to the slides. We've the summary that we've seen is that, and the presentations today that we've seen is that a lot of the so hang on. I should just introduce myself. Anyway, you know all that. I did have long COVID as well. I worked in lots of infectious diseases. I worked in malaria, TB, HIV, plague, SARS, toxo, hydatid, and dengue. But COVID's been the real cracker, really, in terms of interest. It's been a very interesting condition to be involved in. We've had the description of the studies here. People can get better. Many return to daily life. We've got no evidence of microclots or gut disorders causing these conditions. The idea of a persistent viral infection, which is often quite attractive as an explanation to consumers, has been shown by good research, excellent research, to not be part of the process. That it is highly individual, a little bit as Silje was explaining, and that genetics may have a minor role. Genetics has a role in everything, really, doesn't it? So it may well have a small role here. And it comes to really what our three presenters have explained, that it needs a broader understanding of care, and that is what we want to learn and take forward today. So we hope to have a discussion now, but we wanted to embed it in the patient. So here's the panel. Rachel, who I'm going to introduce, is a recovered patient who is a management trainer, recovered patient, and working with a number of patient groups in the UK. And Cédric, you know, professor, physician, and neuroscientist, and psychiatrist, we'll let that in at the end, and globally recognized, as working alongside Brigitte, who's a professor in internal medicine, in cardiovascular medicine, infectious diseases, and persistent symptoms, and recognized in the UK and many other places as a leader in her field. And Silje, Reme, who needs little introduction in clinical psychology and head of the Mind Body Lab, specialist in chronic pain and functional disorders, and also return to work strategies. Rachel has been a long COVID patient and recovered, and we've asked her to, and is doing some work in the UK in this area in spreading messages. So I'd just like to pass to you for your experience.
Thank you, Paul. It's funny, I speak for a living, but when you're speaking about your own journey, it's quite different and more emotional. But I'm Rachel. I had long COVID, and I'm very pleased to tell you that I recovered from long COVID. And I do just want to say thank you to all the speakers and researchers. When you're in these long COVID patient groups, and I've been in a lot over the years, this is not a narrative that's popular. The popular narrative is one of microclots and viral persistence and the virus causing damage to the brain. So my aim is to get some of these narratives to patients. And I would say that the patients you saw earlier are not representative of the people that I talk to who just desperately want to get well. So I've been asked to for a couple of minutes about my own journey and a couple of things that helped me recover, and then what we're doing now to help other people recover. And as time goes on, it's a bit like a frosted glass where you stop kind of remembering so much as to how it was. So a couple of days ago, I came across a Facebook post that I had posted, and I hardly recognize this person, but I just wanted to read it to you. And it was in April 22. So here goes. I know a lot of people have been asking how I am. And I want to tell everybody that I've got long COVID, and it's the most debilitating chronic illness that I have ever had. I'm told the symptoms are similar to ME/CFS. I've spent months just cycling between feeling okay and then feeling dreadful and hardly being able to move. I haven't left the house for days. With every relapse, I discover more things I can't do and less days that are okay. I can't get my daughter to school. I've had to ask other people to do that. I can't walk, I can't run, I can't cycle. All of this causes post-exertional malaise. I can't even do a 5-minute walk. If I do that, then I will relapse. I've had to give up work because I haven't got the energy to cope with it. I've just done a 2-hour Zoom and it caused me to relapse for about the 6th time. I feel utterly fed up. I know that this stress is making everything worse, and everything I try doesn't work and seems to make things worse. And just to put that into perspective, prior to COVID and long COVID, I was training for a marathon. I was busy, single parent, running workshops, very capable. And I literally, at that point, it was a cry for help. I thought I had ruined my life. I had purple toes, I had pain, I looked in the mirror, I was grey, difficulty controlling my temperature. I Googled purple toes and it said that I had COVID toes. So, of course, that made things worse. I felt like I was in a pit. I told my mum I'd ruined my life. And every time I tried to get out of the pit, I seemed to go further into the pit. I didn't know it when I wrote that Facebook post, but it was actually a turning point. And it was a turning point because out of the thousands of people that are in my Facebook network, I found 4 who had had ME/CFS and had recovered. One of them had done the PACE trial, and she said it was the best thing ever. It saved her life. And then I started to find other people who had recovered. And so I knew it was possible, and I decided to learn what they had done. Someone gave me access to the program, Valino, that you have been using as part of your research, and I came across an explanation that made sense to me. And it was that the virus, when you get a virus, it's your body's response to fighting the virus that are the symptoms, and sometimes that response doesn't switch off. And then you get the symptoms and they're so scary that that fear then perpetuates. And it just made sense. I'm not a typically anxious person, but I was living in a global pandemic. And so the world was anxious. And I was kind of in a state of high alert. So I had to learn really to relax, which I've never done in my life. I had to learn to view symptoms differently and be less scared of them. I had to learn to go back to work and life, and I had to learn to exercise, and that setbacks were opportunities to learn something rather than something to pull me back. Since then, I ran the London Marathon in 2023. I've done 2 ultras. I've got another one next month. I've been reinfected. After 8 days, I went skiing and no bad effects. And then I've met others. I've met other people that I now class as friends because they're very similar to me, similar personalities. I joined Coffee. For those of you that don't know, Coffee is a organization that researches fatigue following infection, a group of scientists around the world. And so I joined as a patient representative to try and ask questions of the scientists, to try and understand the research, and to kind of put it in a language that actually makes sense for your average patients. And so we've produced some videos called Fatigue Science Talks. Silje is on one of those videos. People are having video recoveries just watching the videos and getting the explanation. Jake, who's in the audience, who's a clinical psychologist, he's in another of the videos. And again, we're getting feedback. People are watching and just the explanation is making a difference. And I've also set up a recovery channel and something else that I can't read my writing. I've got various, I've just, if you want to hear more about my story, you can just Google my name. I've tried to take every opportunity to tell everybody about the hideous condition and the belief that it is possible to recover. And there are people that have recovered in the audience. Jan, I've just met this morning as well. Thank you.
So clearly no issues with being a driven personality there. So that was so. Let's listen to the second interview from here. So thank you. Thanks for that, Rachel. And I think while we're putting that up,
une thérapie cognitive et comportementale, et ça fait partie des éléments qui, je considère, m'ont sauvé.
Les séances consistaient à parler beaucoup de ce que je ressentais, des peurs que j'avais, peur de manquer d'air, vu que j'ai manqué beaucoup d'air les 2 premières semaines de Covid.
Ce qui m'a sauvé, je peux le dire, c'est justement la prise de conscience, alors, étonnamment, du fait que c'était en partie dans ma tête. Donc, l'entendre dire comme ça ne m'allait pas, mais en réalité, je l'ai compris alors en lisant certaines interviews de médecins qui l'expliquaient, mais de façon très cohérente, avec des exemples comme l'exemple du membre fantôme, voilà, donc de façon très logique, très compréhensible et très pragmatique quand on est rationnel comme je le suis.
J'avais en parallèle de ça un oxymètre qui me montrait mon taux d'oxygène et mes battements de cœur. Et j'étais tellement absorbé par ça que dès qu'il y avait un problème, je le mettais. Et dès que je voyais que ça augmentait encore plus parce que j'avais encore plus de crises de panique. Même si le taux d'oxygène était normal, je voyais mon cœur à 130, je me disais c'est pas normal, qu'est-ce qui se passe, ça fait peur.
Je suis quelqu'un de nature anxieuse, assez rigoureux, assez perfectionniste. Je pense que le Covid long certainement est arrivé sur peut-être cette nature-là, anxieuse, etc.
Plus j'avais de données un peu médicales, un peu scientifiques, plus j'arrivais à me calmer, à me raisonner, à savoir que j'étais pas dans l'inconnu et que ça allait.
J'ai commencé par faire 5 minutes de vélo d'appartement au départ, et puis petit à petit, progressivement, j'ai pu faire de plus en plus d'exercices.
On a accéléré aussi le sport et on s'est remis dans une... Chaque jour on fait du sport, chaque jour la méditation m'a beaucoup aidé pour prendre conscience des messages que pouvait envoyer mon corps et en fonction de pouvoir les analyser et de pouvoir me rassurer.
Ça a commencé à aller mieux, vraiment tout doucement, mais j'ai vu quelques éléments qui allaient mieux quasiment 6 mois après l'arrivée des premiers symptômes en avril. Et puis, je dirais que je n'ai vraiment plus rien depuis janvier.
In fine, ça allait de mieux en mieux. J'ai repris mes études. J'ai repris des activités sportives en allant à la salle de sport.
J'ai repris ma vie comme elle était avant.
J'ai validé ma 3e année de licence avec mention.
Donc je retravaille normalement, je fais des journées classiques de boulot.
Et actuellement, tout va très bien.
So thanks for arranging those videos. They're very, very helpful. And Cédric, we know that you were one of the first people to flag that psychological mechanisms may be involved in the long COVID pandemic. How did you introduce those subjects to the patients? What was the response when? How did you go about bringing that topic up with them?
Thank you, Paul. We had this experience with Brigitte even years before long COVID, as I mentioned. So we knew that for a particular person in a one-to-one interaction, it was quite easy. First, to acknowledge that you know that the symptoms are real, and sometimes you have nothing to say, just listen. 1 minute, second minute, maybe just all the first encounter will be only listening to the patient and acknowledging that everything is real. And then introduce everyday life example of conditioning, something that you have experienced as the patient had. Something is very normal. There's nothing special with them. This is something happening in everyday life, in every hour in our brains. For example, we have many examples. For example, if I am thirsty, I will take a glass of water. If I run the marathon without enough water, I will be very thirsty. Then I will drink a bottle of water and then thirst will disappear. But the water is in my stomach. I'm still dehydrated. People already experienced that. I did. And they know it makes sense. Then we move to example from medicine, because, you know, with real disease such as cancer, chemotherapy, many people know nausea condition with chemotherapy, with people having encountered chemotherapy as a poison, not as meat, but quite the same, a real poison for them, and then some of them developing nausea without chemotherapy, before chemotherapy. So the trigger is real, and I think it's something important for those patients. We do not say that it has nothing to do with the virus. The virus is the first stone, but then other processes are taking the lead. And during this discussion, usually things are going well, but the other way it's very difficult is to discuss as we are trying to do just now in small posts on Twitter, etc. In a collective audience, it has been very difficult. I do know how to do that. The word psychological, I can use it with a patient in one-to-one interaction, but in other contexts, psychological is felt as an insult. And really, I did not find a result. We can change words, but I guess that using new words will work for some days, and then the problem will be the same. But I'm not sure.
Brigitte, both of you are just sort of such kind clinicians. I would have liked to have been your patient, you know, and yet people, there's this diversion with the public narrative and personal attacks on you and on your work. How do we get over this? What's behind this? What message do we give to the public? I mean, we've got messages we can give to patients which are clear. How do we change the public narrative?
Yeah, obviously I don't have the response, because otherwise things have gone differently this morning. Yeah, it's been very painful for us, all those comments on the social media, and I've stopped reading them because it was too complicated. I lost my sleep, and it was very complicated for me. But I continue because I know I was doing well for the patients, because as Cédric said, when I'm in one-to-one situation with a patient, it always goes very well, and I've seen a lot of patients recovering, so that's why we continue. But at some moments, I wanted to stop because it was too difficult to bear those very violent comments. Well, so I don't have the solution, but I think one of the problem is that the public and the healthcare providers do not know anything about those mechanisms. It is not learned in the medical curriculum. That's a big problem, even for psychiatrists, even for psychologists. And I think the most important thing is to put that in the curriculum of all healthcare providers, because those mechanisms are really ubiquitous. It is the normal functioning of the brain, and yet we don't know them. So that, for my opinion, this is the first thing to do.
So tackling getting into the medical establishment as well as the public. I mean, is that something that's happening in Norway and in other countries around in the area, or is there a focus on the public narrative as well? Maybe it's different for different countries. You have to do different things. But where would you, Silje, think that we should start with this re-education or nuancing the messages?
First of all, I think it's important to continue to stay in the field and to communicate and to speak in public and to speak in the healthcare system, in the educational system, to get this knowledge, which it really is, this updated knowledge out there. Because I think that the big mistake was to introduce the biomedical model as the only model, and not only that, but as the best model, which is on the top of the hierarchy and everything else is your fault, which is a mistake that I think our system is partly responsible for, and we need to sort of correct that. And we can do that by telling the stories of recovered patients, as you are doing bravely. And we can do that by providing explanations. So to help people understand that psychology is not the reductionistic, your fault thinking that people think. It's actually biology. These models that we're talking about, these treatment models they work, that don't replace biology. They work through biology. So I think we need to get that message across in the education of medical and psychology and all health professionals. And we need to get it out there in public. And in order to be able to do that, we need to stand together and to support each other. I think that's crucial.
Yeah, I mean, it's what's striking for me is the richness of the metaphors, of the way you explain, all of you, and what we've seen on the videos, or of explaining things to patients using models and metaphors. It's huge. Sitting in the chair, it is. It is quite. It's gone all heavy again. But it's how we get that beyond just one-to-one communication. But it seems from the patient groups, where are patient groups getting their information, particularly the recovered patient groups? Are they getting it from medicine, the internet? Where are people getting the information from at the moment?
It depends which group you're in. There are it depends which group you're in. I mean, there are groups that I've been kicked out of because you mentioned the word recovery and they say, well, recovery isn't possible. You couldn't have been ill, and then you get kicked out. And so there's those narratives. And then there are starting to be some groups that are a bit more receptive. I mean, when I recovered, I still thought that it was the virus that was the problem and I needed to heal from the virus. But if I got my brain in the best possible way, then I would help recovery. And then over time, I've realized that probably what Cédric talks about is probably more the case. There are some pain groups that I joined and somehow it feels more accepted in pain, or it feels easier to get because there's not all the news about the virus and the microclots and all the kind of noise of the research. So in the chronic pain field, when COVID came about, they were very quick to say this is another mind-body condition. So maybe to be talking more about pain and then to start to introduce the concepts to long COVID.
Yeah, certainly pain for some reason seems to have less emotional baggage around it as an explanation and segueing in things to do with chronic fatigue. And I mean, you know, one of the things that we all talk about is recovery, and I know Jake has. It took a little bit longer in some ways that you've made public in your video appearances. So, I mean, what I often hear people say that they're 90% recovered or they're 80% recovered. What is that? Something you hear about, and how do you explain that to people from a medical sense and from a psychology and neurophysiological sense? The 80% recovered. I'm nearly there, but not quite.
I can tell you what happened to me. So I announced my recovery. I recovered very quickly. A 10-second conversation got me back running. I announced my recovery really publicly. It was seen by thousands of people. And I thought that was it. I was recovered. And then I got some kickbacks, probably because people were telling me to wait for the crash, and then it came. And so probably I was 80% then. I think when you're 100%, it's not that you don't get sensations. These are normal. Everyone gets sensations. Everyone gets stomach aches when they're stressed, or brain fog when they're worried. But you're no longer looking back, worrying about when the next crash will be. You operate normally, you do a normal amount of exercise, a normal amount of work. And so I think when people say they're 90% recovered, then the beliefs maybe haven't quite caught up in terms of what it is, and they're still waiting for something to happen and living maybe quite carefully. Whereas I don't do that anymore. I just live.
I often have patients who say that they are recovered, but they are rehabilitating. So they flipped their narrative. They got a new understanding. They got an experience that this is actually something I can influence. It is not something happening to me, but I can do something myself. And they got a dramatic change, but still they need to sort of train like I would train for a marathon. And the body has maybe been inactive for a long time, and it needs to rebuild. So that's one version. I also think that 100% recovered, what does that really mean? Does that mean like no symptoms at all? The World Health Organization's definition of health, which is nobody's there. I mean, that's not literally not. You have to be like, it's like in I don't know. It's just, yeah. So that's also a question about what is a normal state, what is a normal situation, and to experience symptoms once in a while, but to be sort of recovered from the chronic condition. I think that is that's crucial.
Yeah, from my experience, the patients have recovered 100%, but not all the time. So they have several relapses due to different things, or the viruses, or other bad experience in their life. But they now know how to deal with it more quickly. The symptoms are less severe. The recovery is quicker. So, but sometimes they are completely normal, actually.
I also want to say that how I often explain this with kickbacks to patients is to say that the highway, the sickness highway in the brain, it doesn't go away. It will still be there, but we have just created a lot of new ways and start associating activities and movements and signals in the body to safety. But you can still, in certain situations, go back to the highway again. But that doesn't mean that you're sick again. It just means that you need to find the way out again. And then you have the sort of the techniques and support to do that.
Yeah, it was explained to me that the brain is like a pony that goes round the track and goes round the track and goes round the track. And still now, if I get a virus, I can feel that pony want to go back. And I have to talk to it. I have to make sure I don't Google.
Yeah, there was a patient we interviewed actually who said when she felt the symptoms coming back, or she felt she was a bit anxious, she'd call them Bob. And she'd say, "Not today, Bob," and "Go away, Bob," which is quite a nice technique. I mean, so one of the findings of the EU research project is that the clots, the viral persistence, are were not found to have any evidential, weren't causing these symptoms. Are those ideas still circulating? How much more findings do we need to disprove these? And are these beliefs about biomedical causes, how important are they in the public narrative? Do people still talk about this with you in your clinics?
Maybe we should think about why people need such an explanation, and why do they favor this kind of explication over other explanation. There might be some medical explanation. For example, the biomedical model might be the best for certain disease. If you got lung cancer, you will be happy to meet the right physician who knows the exact drug to use regarding the genetic variation, not on your body, on the very cells, on the very tumor. And this biomedical model, one cause, one disease, one cure, could be save your life. But then, because it's very efficient, there is an assumption which is unproven. It's that every disease could be cured that way, because after a while, lung cancer 30 years ago, if it's not taken early, you will die. And it's no longer the case. So this idea has spread with the same level of evidence in the mind of doctor, physician, public, etc. Biomedical model could save your life and it's very efficient in some situation, but it does not mean that it will fit every disease, and it does not, as Silje said, and as everybody said. So this is something from medicine. And the other thing is that we have to acknowledge that in the society, biological explanation are more valued than psychological explanation. And I think people who fight for their rights, they know that, and they have experienced that. So it's difficult for us to say, those people, we have to educate them and then they will understand what we are thinking. They have also a strong experience that if you have a psychological explanation, you will not be considered the same that is if you have a virus. So we have to acknowledge that. So probably it's something more about the society and the way we look about explanation. And I will not be too long, but in my own discipline, in psychiatry, I see that the search of biomarker became over the 2 last decades the grail. Whereas the psychiatry has long been the medical specialty with a true biopsychosocial approach. And I observe that it's more and more oriented toward purely biology. So I think it's something very much broader than long COVID. I don't know if it helps.
Yeah, it does. I mean, one of the questions I was going to ask you is you showed this clear relationship with long COVID and announcements in the press and so forth. So if you were, what would your therapeutic targets be in a biopsychosocial approach? What would your therapeutic targets be to alter this narrative that seems to make people ill? Because Harold that.
Yes, I will have the Nobel Prize if I can answer this question now. Really, I don't know. I think probably be careful to have a balanced view. When talking about recovery, we forget to mention those patients who do not recover, and the reverse is true. But if we want to be heard, we have to mention that there are possibilities to recover. We have techniques, and probably we will have better techniques in the near future, but we only help a part of the patients. To be heard, we have to say that. And I think it's humility. It is important to be understood with a broader audience. But possibly, as we all mentioned, to have these mechanisms taken more seriously, perhaps we should have a movie with something like this. Sometimes, you may educate people with long Lyme, and then a celebrity with long Lyme may post a story, and it's over. You would just waste your time.
I mean, Simon Wesley said at a recent meeting, a clinician from the UK, a psychiatrist in the UK, who was involved in some of the early research in this area, that they thought the science would stand, right? And as researchers, I guess, do we in this audience, do the panel feel that the research should stand by itself, or is there something else that we need to do in our own context? I mean, Silje, you're involved in this at a national level. We've got Harold here in the audience, what are the programs that we could do at a national level that's more than just standing by the science?
Well, I belong to those who believe, like Simon, that science would stand for itself. If we can just show, demonstrate good evidence, following scientific rigor and publishing in good journals, that would speak for itself. And it doesn't. In this particular field, in controversial fields like this, it doesn't. We need to do more, and we need to approach it from other angles. And I have to say that I've been surprised by what a positive role media can play with the project that we did and the effect that has had. It blew my mind to see how effective that was in conveying knowledge and gaining interest, not only from the general public, but from the healthcare profession, wanting to learn more, wanting to get updated, wanting to get more knowledge so that could help patients even better. So I think the general public and also healthcare professions, if we're honest, are really, really dualistic in the way we view people and disease and illness. And if you see a person, and the closer to you it is, the stronger the experience is, that is really, really sick with bodily symptoms, it's really hard to believe that can be only the brain. It's so difficult for us to make that bridge. And I think we need to help the public in various ways with good research, but also with good communication and real examples.
So that's great. And I was with Howard Schubner last week, who's an American working chronic pain. And he said, well, part of it's going to come from us lot, but part of it is going to come from patients and communities and people finding out for themselves. And I don't know whether Zita or Jan is in the audience. You're patients, and you've just done a 6-part series in the science behind long COVID. Do you want to have a comment?
Yes, thank you so much for mentioning this. So yes, I'm Jan. I also had long COVID myself, and recovered. And yeah, it's actually only because of other people that told their story of recovery, notably also Paul, that we found out about this new explanation and the possibility to recover. And so we really wanted to give that to further people, and especially in Switzerland. So we are from Switzerland. It is really not known. And yes, the idea was to make a podcast series on that subject. So the last episode came out last Sunday, and so far we had a lot of good responses. So maybe, do you want to say something?
Yeah, so I'm his partner. I didn't have long COVID, but I experienced his. And just what you were saying, Silje, and the importance of media, I think that's what we are experiencing right now. We get many feedback, not only from patients, but also from a lot of healthcare workers that then also connected to Basel, which is here, and working with these methods. So doctors that are contacting them now, and I think also as patients and family and friends of patients, we have another stance in also spreading hope and being more, maybe we can speak a bit more clearly than science can do, because we're a journalistic project and not doctors or scientists. So I think I can relate to that, and that's also what we are seeing right now, that there's a lot of feedback.
Yeah, I was just trying to get across the idea that it perhaps is just not just the professionals, but the patients and other community groups, that what happened earlier on today isn't entirely representative of all patient groups. Are there any comments or other quick? Pardon? Yes.
I think it is a paradigm shift as a patient, because you cannot believe that if your toes are purple and you're grey, that it can be driven by the brain. But I remember suddenly realizing, because I'd built this evidence up where I could walk inside my house but not outside my house, and whenever I kind of had work coming up, I would get worse, and when I cancelled, I'd immediately feel better. So it was actually quite a relief to suddenly realize that I had influence and that I could do something about it. But it is also a paradigm shift. I remember when I finally worked out that I wasn't intolerant to exercise, but it was conditioning. I describe it as suddenly realizing that the world is round when I thought it was flat and everyone else thought it was flat. And then once you see it, you can't unsee it. But then you're trying to talk to people that can't see it. So it is hard.
Do you think, Silje, this should be in primary schools, right? You know, that these ideas should be inculcated before you get unwell, in a way. I mean, that would help, wouldn't it? Because pulling you back from the cliff when you've got the purple toes and so forth is quite hard.
Yeah, I mean, it should be a part of the updated biology classes in school. Of course, it should be, and I think, but I think on the prevention side, I think that's a healthcare system that understands this and accepts every patient with respect, regardless of explanatory model for their symptoms, is going to be a huge preventive effort if we can have that happen.
I'd like to thank everybody very much. I'd like to thank Leva, who helped us organize this and put this together, and you two who've been absolutely fantastic with the whole thing. Thanks to the panel. Thanks for listening.